This week, I'm going to share with you the second recording that I gave for SEMPA, the virtual SEMPA course, the Society of Emergency Medicine Physician Assistants. It was a great conference. Thank you so much, Fred Wu, for letting me be a part of it, and SEMPA and everybody else. I shared the extreme ultrasound cases with you about maybe a week or two ago. And in this lecture, I'm going to share with you guys my top 5 best ultrasounds. I'm kind of tricky with it. Like, it's actually 15. It's my top 5 general stuff, my top 5 techniques, and my top 5 specific scans. Check it out and let me know what you think.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Hello, my name is Jacob Avila. I am currently working at the University of Kentucky in Lexington. And in my lecture today, I'm going to talk to you about some top 5s. Now, there are a couple of different top 5s that I was kind of thinking about doing. So I decided just to do actually like 15, but do 5, 5, and 5. So 5 general, 5 techniques, and 5 specific tips that I think are beneficial. Now, as far as conflicts of interest, I have done independent contractor work for a few different ultrasound companies, and I run a website called coreultrasound.com, along with some help from Ben Smith and Taryn Trott. We also offer some courses on that website as well. Let's start with some general 5s. Now, probably the most important tip that I can give you guys is to scan normal patients and also scan known pathology. The way to learn how to use ultrasound, especially with critical diagnoses like aortic dissections, is not necessarily to use it to primarily diagnose your patients. But what you can do is you can have a patient that has a known dissection and go back with that ultrasound and say, hey, do you mind if I take a look at your dissection? There's nothing wrong with that. And in fact, I've had, 3 people in my entire career out of thousands of people that I've scanned that have said no thank you when they asked them about ultrasounds. Learning about lung pathology, which that's actually my favorite application of ultrasound, I learned that via diagnosing it with a CT scan or an X-ray, and then going back with that ultrasound and trying to figure it out kind of retrospectively. It's a good way to learn. Remember, especially if you're just starting out, the point of you doing the scans retroactively is not necessarily to change patient care. It's to be able to increase your ultrasound knowledge and learn a little bit more. Tip number 2, save your scans. What I do is I have a thumb drive that I keep at work. It never leaves work. And then I have an encrypted hard drive. And what I do is I will save my scans to that unencrypted USB drive that doesn't leave work. I then will put that into a computer and attach my encrypted drive into that computer and transfer the stuff into my encrypted hard drive, and that's where I save all of my scans. And I actually have them all organized. Now, these are scans from when I started residency in 2012. I basically save everything, and you can see I have it all filed out here so that I can see it very well. I can refer to it, and I will tell you that sometimes I'll have done a scan a few years ago and then go back later with a little bit more knowledge and then realize that my interpretation wasn't correct. So a good way to do your own image review. Finding a mentor is a great idea. I mean, there's no Fellowship of the Rings without Gandalf, and there is no X-Men without Professor X. And kind of along those veins, if you want to be really good at ultrasound, you have to find people that you can ask questions about, that you can have a little bit of guidance from. Now, I have a few of my mentors here. The first person that told me about ultrasound is VM Din. He's in that top left-hand corner right there. He works out in Loma Linda in California, where I went to medical school. My ultrasound director in residency was Dr. Ben Smith. He's the top middle. And then the bottom middle is Matt Dawson, who was my fellowship director in Lexington. And then the bottom right is another big mentor of mine, Mike Stone, who has been someone I can always shoot emails of. And this is not an exclusive list. I have a lot more people that I really look up to and want to be more like when I grow up. You need to watch, listen, and read. you're not going to just passively learn ultrasound. You have to actively be engaged. Now, this may be going to an ultrasound course. It's a good way to get a good introduction, especially if they have hands-on there. I know in the time we're in right now, COVID, it's a little bit difficult to get in to conferences safely. There are a lot of online options. Ben Smith and I recently have debuted the courses.coreultrasound.com website where we offer courses there. We actually have a fundamentals course and an image review course coming up very soon in the near future for you guys to check out. So look for that. You can read your own stuff, which is actually like a good idea to get your own kind of background information and learn things at your pace. This is a journal club that I had with my residents a few years ago. It's good, but sometimes you need to just kind of do your own research, your own information, and the internet is a really good way of doing that. There are a few different modalities that you can use. You can just straight up Google things, which I honestly do fairly frequently. You can look up blogs, you can look up PubMed, and you can listen to podcasts. All those are good options. Now, as far as online blogs, now this is a good place to start. POCUS Atlas, run by a friend of mine, Mike Macias. He has a lot of 1-minute tutorials on there and a lot of pathology and normal clips, a great reference. I have Core Ultrasound where I have 5-minute sono, which are 5-minute explanations of every ultrasound modality, not everyone, but a majority of the ultrasound applications. On the Core Ultrasound website, we also have Ultrasound of the Week, which is a weekly, sometimes it's like bi-monthly, depending on how busy we are, where we do a case. So it's a written case, and then we give you an explanation as to like what the answer was. We also publish image review sessions on there where it's just me and other guests, often Taryn Trott, who's another physician that works out at UK where I work. He's also a critical care doctor. We'll go through cases together just to kind of walk you through basically how we do it with our residents where we work. Also, the Ultrasound podcast is on there, a bunch of tools, and we have a clip bank where we have a bunch of normals and abnormals that you can download and use for your lectures. UCSD is run by one of my actually recent friends, Amir Aminlari. He works out at UCSD. He's a fellowship director out there. Great project. Ultrasound Gel is predominantly a podcast, but they have summaries on their website. It's ultrasoundgel.org, where they basically do reviews of ultrasound literature, which is good. Nobody else is really doing it as well as Mike Prats is out at OSU, or Ohio State University. I'm also one of the contributors and one of the co-hosts of that podcast. Highland EM is a great place to learn about nerve blocks. It's actually where I refer to. And then the EDE blog is another great online ultrasound resource. Now, if you really want to get down to the nitty-gritty, really understand the literature, the techniques, you got to look on PubMed. This is the source of all of the data and is where all of us who create online content, where we all go to learn new techniques and to really understand if we're using something adequately. So you can go to the PubMed website and there is a search engine on there. Now, here's a problem with a regular old search engine is it's not very good if you just type in lung ultrasound. I mean, look, there's 100,000 results and every like two titles actually talks about ultrasound as like genetic things in there, things that we don't really care about all that much with our point of care applications. So what I'd suggest doing is you go over to the advanced function, which is right here. So you click that advanced function and you can actually tell it exactly what you want to look. So let's say that there's a specific thing that you want to look for, like lung ultrasound. Type in lung and you can add it to the query box and then add another one. And then when you hit search at this point, it's only going to show you articles that have lung ultrasound in the search box. So now you can see that it's all stuff that has lung ultrasound in the title, and the amount is much more manageable. It's only 2,000 things instead of 100,000 topics. You can also add that to something else. You can click advanced again, and you can basically customize exactly what you want to do. So it's a good way of looking. Now, you might not run into this issue, but I frequently will read an article, read a second article, and by the time I get to the third article, I don't remember what I read for the first article. It happens a lot. I have a very short attention span. So what I started doing is I started creating these things called evidentiary tables, which is where I basically write down the data from the article. I'll put it in a Word document that I can consistently add to and I can refer to when I'm doing research. And this is especially important if, let's say, I am looking up something about cardiac ultrasound. I spend a week just really getting into pericardial effusions, for instance. And then let's say a year later, I go back into it. I'm like, oh man, I remember doing all of this research on pericardial effusions. Where do I go? Like, how do I remember? It's all there. I've written it down. I hyperlink my references on there so that I can look up exactly the article. Because sometimes I maybe had the information a little bit wrong, or I think an article might actually be useful for me to look up more stuff for that particular topic. So I'll just click here and boom, it opens up the article for me. So it's not for everyone necessarily, but this is the way that I like doing them. Now, it definitely takes a little bit more time and some discipline as far as creating these evidentiary tables, but I really think that they're hugely beneficial because it just maximizes your peripheral brain. You can update it as you move forward, and really long term, it's going to save you a lot of time because you don't have to reread all the stuff you've already read. Now, the last general 5 tip that I have for you is to practice. You can definitely do this at a course for sure. Practice on your patients like we mentioned. And you can practice procedures. I mean, procedures are a little bit tricky. Like you might not want to do your very first ankle arthrocentesis on a real patient. A good place to start anytime that you're thinking about techniques is to start with ultrasound guided IVs. I am very strongly in favor of us doing ultrasound guided IVs. This is, in my opinion, the most difficult ultrasound guided procedure that exists and also the least risky, which is actually good. So if you get really good at a very difficult technique that's low risk, the easier techniques that are higher risk are going to be much easier for you and you're much less likely to cause harm. Here is me doing a ultrasound guided IV on a Blue Phantom simulator. You can create these at home. This is one made out of Knox gel that Jason Bowman, who's one of my former residents, and I made. We didn't like invent this technique. This is just one that we made. And Jason and I actually created a bunch of tutorials on the Core Ultrasound website. There's a section within 5 Minute Sono that is called Sono Instructables, and we like walk you through exactly how to create these. And you can see, and you can do this with Knox gel. You buy it at the supermarket. You can create it with just pots and pans at your house. And you can see here that it looks pretty good. Like we're using a Penrose drain in this instance, which is something that you can just get from your hospital. And you can see that it looks maybe not 100% as good as the Blue Phantom, but it's much cheaper, much more accessible, and it's a good way to practice. You can also create a ballistics gel simulator, which there's the URL for that. We have tutorials on how to create that as well. And you can see here that these also look pretty close to what we see with the commercial simulators. Commercial simulators are great, but if you want to create one for a little bit less money and reusability at your house, you can definitely do it with Knox gel, ballistics gel, and there are a bunch of other ways that you can do it. All right, let's shift to some technique 5s. You want to use large movements, then small movements with your ultrasound transducer. That's especially important when you're using cardiac ultrasound. Think about it like a microscope. You have a coarse tuner of a microscope, and then you have a fine tuner of a microscope. Coarse, big movements until you see the thing that you want to do. Once you see the thing that you want to see, then you do these little fine movements to really hone in on it. And that's how I approach the peristernal view or any peristernal view, long axis, short axis, same thing. So I start off doing these big old circles until I identify something that looks like a heart. And then once I get to that spot, then I do little tiny tweaks to try and figure it out. Remember, and this is with cardiac ultrasound, pressure is okay. It's okay to push a little bit hard. If your patient winces a little bit, especially if it's for something that is maybe life or death, it's okay. I mean, I don't want to cause harm on our patients, but if you ever watch your patients when they come back from the echo lab, they have red marks all over them. And those examinations that our echo tech colleagues do are like an hour long, and we're spending maybe 5 minutes doing it. So don't forget, you can push down hard. You can move the patient. If you are not getting a great view of the peristernal views, what you can do is you can actually move the patient to their left lateral decubitus. get a much better view of that and even get a much better apical 4-chamber view. It helps as well if you have the patient, let's say, take a big breath down. That can actually make it easier to see a subxiphoid view because it's bringing the heart closer. Additionally, if you're trying to look for the gallbladder, having them take a big breath down will actually bring the gallbladder down a little bit lower, and you'll be able to see it there. Also, if you have your patient move to their left lateral decubitus, you can also see their gallbladder a little bit easier because it like swings the gallbladder out from underneath the ribs. It's really strange, but the organs in the body, I didn't really know this before I started ultrasounding, they're not really fixed. You can do maneuvers to move the organs around. So if you're having issues, don't forget to do that. Make sure that you brace your hands. For diagnostic ultrasound, this is important for fatigue and making sure that your arm doesn't kind of move down. Look over here at my wrist. My wrist is actually touching, or the palm of my hand is actually touching that patient's chest to make sure that I have no pressure. First off, no excess pressure I don't need to put in. Second off, I'm not sliding anywhere, and I have really fine motor control. This is especially important when you have procedural-based ultrasounds. You don't want to have your arms kind of floating up top, right? You want to make sure that everything is braced so that you don't get fatigued and you have really fine motor skills. Depth. This is something that when I am doing image review for my residency, I often see these images. They might be great views, right? We have an apical 4-chamber view over here. We have a view of the lungs over here, but all of this is just wasted depth. Now, when you decrease the depth, you're not really zooming in. What you're doing is you're actually changing the way that the ultrasound machine will send out sound waves and listen. So your image actually gets better when you have more shallow depth. You can see I have way more resolution of this apical 4-chamber view of the heart, way better resolution of the lung sliding here. All right, now let's move on to the last section, which is some specific techniques. Now, airway. Airway is something that I don't really have a specific technique for it other than it's doable. You can totally do it. Here's kind of a side-by-side. Now, you can see here the trachea has a bunch of air shadow underneath it. This is the jugular carotid over here. And here's the esophagus. And you can see as this provider accidentally intubates the esophagus, I can see a second trachea form over here. Here, I'll rewind it just a little bit to right here. So we have like two tracheas. There should only be one air-filled structure in the throat. And in this instance, I'm seeing two. That means that's an esophageal intubation. And then I had the student or the resident pull back and then try and get to the trachea. And you can see that we have a bit of an artifact change within the trachea over here, confirming that we have an endotracheal intubation. Now, this is not something that you need to do for everybody necessarily. If you have a situation where you have a learner and you do not have video laryngoscopy, ultrasound is great for that. Very good accuracy in the high 90s, sensitive and specific when compared to capnography. The other thing is if you have, let's say you have video laryngoscopy, but you have so much vomit or you have a lot of blood where the video laryngoscopy can't be used, this is when the ultrasound really shines. So not necessarily something that you need to use every single time, but something that is helpful in certain situations. Now, with regards to cardiac, this is where a lot of people struggle because it's kind of difficult. We talked about a lot of them already, which is kind of big movements and then small movements to kind of do your coarse tuning or fine tuner of the microscope. You can have the patient move over to the left lateral decubitus as well. Those are some big tips, but let's go through a few more specific examples. This is an apical 4-chamber view, and this is a problem that I see fairly frequently. So you see how this is kind of tilted off, it's kind of diagonal. The way you fix that is by actually bringing the tail out a little bit more laterally. So right here, I'm going to bring it a little more laterally, and boom, I'm getting a much better view. Remember, the heart actually sits diagonally this way. It's not just like up and down, it's sitting sideways. So if you just bring that tail over, you're much more likely to get it right at the apex and shooting straight through towards the base of the heart. So right there, great views. Now, if you have a view like this, you have a little bit too much ventricles and not enough atria. What you do at that point is you just got to flatten your tail just a little bit. Boom, you're getting a great view of all of the 4 chambers. And then if you are getting a apical 5-chamber view, which that's what we're kind of seeing right here at the beginning, that's actually the aorta right there. It means that you just need to adjust your tail and flatten it down ever so slightly or lift it up just a little bit to get that aorta, that 5th chamber view out of the way. Now, we talked about this one, about getting a good parasternal long axis view, that you want to do kind of like little big movements, big circles, and then little rotations. It's a good move. Now, if you run into this situation here where you're not really perpendicular to the axis of the heart, so see how this apex is a little close to where the transducer is? What you can do is you can actually physically move the transducer away from the apex towards the base of the heart. So watch here, I'm going to move up just a little bit, and then boom, I have a much more perpendicular view. Sometimes we get an oblique view kind of in between both of them. Just rotate your tail until you get that ventricle nice and elongated. Now, with the subxiphoid view, a big one is making sure that you're gripping an overhand grip. So pretend this camera is the transducer. You're going to do an overhand grip and kind of push it into the subxiphoid region, which most of the other transducers, you're holding it like this, like a pencil grip. So here is an overhand grip of that subxiphoid view, and I'm pushing pretty hard underneath that xiphoid. Remember, you have to get that beam underneath the xiphoid process to reach all the way up there in the heart. And sometimes you got to push pretty hard, kind of like you see here. With the lungs, I'm going to talk more about exactly how I use lung ultrasound. There's two different ways that you can do it. You can do it in a protocolized manner like the Blue protocol, or you can do it more of a pragmatic approach, which is really more what I do. I'll get a history, I'll even do my physical examination first, I'll develop my differential diagnosis in my head, and then based off of what I think is the most likely thing, I'll either start in the anterior chest or I'll start in the posterior chest, rather than scanning everybody exactly the same. Most of the time in the emergency department where I work, I have an idea of what I think is going on. You have a young patient, he's super tall, plays basketball, he's got like super long spindly arms and stuff, and he has sudden onset of chest pain, diminished breath sounds on one side. Of course, I'm going to start by looking at pneumothorax. I'm not going to start by looking for a pleural effusion or for pneumonia, right? So this is how I scan. And this is ultrasound in general, I'm usually asking myself a specific question. Does this patient have a pleural effusion? Does this patient have B-lines? And then I'm looking for that thing specifically. With the aorta, this is something that can be a little bit difficult with a lot of my patients because they have a lot of bowel gas. You can push harder. This is one of those examinations where you will be surprised how much pressure you can apply before you actually cause any discomfort whatsoever. I hold down pressure and just wait for that bowel to peristalsis out of the way. Sometimes I'll even use my other hand to kind of create a higher surface area so that bowel can kind of get out of the way. Make sure you decrease your depth as well, just to get that better visualization of that aorta. Another thing too is if you're having too much trouble with the anterior part of the abdomen, you can actually go transhepatic. This right here is the liver, this is the IVC, and here is the aorta that I'm actually able to visualize through the liver. And here's another one right here. There's a pleural effusion right here. It's actually helping me visualize more of the thoracic aorta over here. But you can see that you can identify the aorta on this one. Now, as far as procedural-based ultrasounds, the most important thing is to always follow that needle tip. Never lose sight of that needle tip. That's where you run into problems if you lose sight of that needle tip. If you look at the central line literature, there's still some incidences of carotid cannulation of pneumothoraces with ultrasound guidance, and I'm convinced that it happens because you don't have good technique, which accidents can happen all the time, right? But you're much less likely to have a mistake or create a complication if you're following that needle tip. So I use something that I've called sequential needle tip tracking. Other people call it other things, but I like sequential needle tip tracking because it describes the technique exactly the way that it should be done. So over here, I have the skin surface. This is the vein, and this is what the ultrasound is seeing. And then here's what's actually happening. Ultrasound transducer, ultrasound beam, needle, skin, ultrasound beam, vein. Now, I'm going to bring that needle, advance it until I see it on the ultrasound screen as a dot. And the instant that I see it as a dot, I stop moving my needle, I move my transducer distally 1 millimeter or 2, and then stop moving the transducer and then move the needle. So I'm doing things in a sequential point of view, sequential manner, to make sure that I'm always visualizing the needle tip. The issue is that the ultrasound machine cannot tell the difference between the shaft and the needle tip, right? So you have to help it understand that. And here is me doing that technique on a very like small and far away vein. You can see I'm not moving the two things at the same time. I'm moving them sequentially. Now, this is just basics. If you really want a good review on how to perform ultrasound guided IVs, head over to my website, coreultrasound.com, go to the 5-minute sono section and check out vascular access. If you get good at this technique, ultrasound guided IV, every other ultrasound procedure is going to be a piece of cake. You're going to be able to handle it. Over here, I'm performing an ulnar nerve block for a boxer's fracture. This is an ultrasound guided paracentesis that I'm doing over here. This is an ultrasound guided pericardiocentesis in a mannequin. Right there, we're getting right into the pericardial sac. And then over here is an ultrasound guided, there's my needle, ultrasound guided joint aspiration. This is a glenohumeral dislocation, and I was trying to take some of the clot out and then put lidocaine back in. So all of these techniques, the building block is ultrasound guided IVs. There's a lot of stuff. To recap, for our first section, number 1, scan known pathology, scan normals, just scan everybody. You got to get your reps in. Number 2, save your scans. This is good for QA, and it's good if you ever want to teach ultrasound. You'll have your own images. Number 3, find a mentor, find somebody in your department, find somebody online, maybe even on Twitter that can help you out if you have questions. Number 4, read, watch, listen. You got to read information, listen to information in order to internalize it. Number 5, don't forget to practice. For our second section, this is regards to technique. Remember, large movements, then small movements. Pressure is okay. You can move the patient around. They're not fixed. Brace your hands, especially if you're doing procedures, and then make sure that you have adequate depth. And as far as techniques, we just went through this section. We got some airway tips, cardiac tips, lung tips, aorta tips, and follow the tip when you're doing any kind of ultrasound guided procedure. That's it for the lecture. My name is Jacob Avila. The website is coreultrasound.com. There's my Twitter handle, and there is my email. And looking forward to your questions. Hopefully that was helpful for you all. If you have any questions or comments, please feel free to email me at ultrasoundpodcast@gmail.com or on Twitter at coreultrasound. And check out the courses.coreultrasound.com website. That's where we put all of our previous courses, and we're working on something really sweet. Actually, we're working on a question bank that we're going to share with you guys hopefully in the next month or two, where I think we have like 3,100 different ultrasound pathology cases, and we're having you identify them, and if you're right or if you're wrong, you get feedback on it. It's pretty sweet. And then we also are going to create another fundamentals course that takes all of our ultrasound stuff that we've created over the past 7 or 8 years. Let me put it in a course with CME questions for you guys, also coming soon. Hope to hear from you soon, and happy scanning.